Okay, I think we're going to go ahead and get started to keep everything on time. So it's a great honor that I get to introduce a physician scientist whose career has fundamentally changed the landscape of cancer treatment, whose contributions to pancreatic cancer research have improved the lives of countless patients worldwide, Dr. Daniel Van Hoff. But first, I wanted to give you a little bit of background about the Ruth Brufsky Award. So I think Ruth and Alan Brufsky were a great couple. They grew up in New York. They had a great family, well accomplished, including an oncologist, Adam Brufsky, who works at the University of Pittsburgh. He wanted to recognize his mom. You know, they were childhood sweethearts. We always, as you could tell through the theme of Pancreas Fest anyways, these are like why we're in the business of taking care of the 16-year-old with pancreatitis, or the tragic stories of pancreas cancer that were shared even by Dr. Srivastava. These hit home. This reminds us and gives us our energy to keep the fight. And so she raised her family. She was quite accomplished, and then even went back to school at the age of 40 to become a lawyer. And she was an education lawyer, helping people that were having a hard time in life, underserved people. And then she was attacked by that dreaded disease of pancreas cancer that took her way too soon. And so in their honor, the Brufsky family got together and made an endowment for pancreatic cancer research, and agreed every year for part of that portion to come in here and to allow us to give the Ruth Brufsky Award to not only recognize her, but obviously our accomplishments in the pancreatic cancer field. And we've had a list of outstanding awardees, including Sudhir Srivastava, who's in our audience today, from 2023. And today I'm honored to add Dr. Daniel Van Hoff's name to this list. His journey actually became not too far from here, Oshkosh, Wisconsin. And I did verify this. So initially, according to the internet, when I was trying to get some good little trivia on Dr. Van Hoff, that he actually attended a one-room school while in Oshkosh, and he says that is true. Lakeland Elementary, or Lakeland School, if I remember right. He subsequently went to college at Carroll University, where he's actually recognized about a decade ago to be one of their distinguished alumni. It's now a university. And then he went to Columbia University, where he earned his medical degree, completed his internship and residency at UCSF in internal medicine, and then went on to the NCI, where he did his oncological training. From there, he went to the University of Texas Health Science Center in San Antonio, rapidly built them up, and as Dr. Zhang said earlier today, was one of the founders of their Institute for Drug Development and Cancer Therapy and Research Center. And then he transitioned over to Translational Genomics Research Institute, TGen, and whereas now he's a distinguished professor, and also has an appointment at the City of Hope. He resides in Phoenix, Arizona, and he has a shared appointment as a professor at the Mayo Clinic, Scottsdale. And it's hard to believe. If you look at him, you wouldn't believe he's been in the business for about 50 years. He's developed many of the new therapies, as was alluded to, countless new drugs that he's helped test, including 3 of 4 FDA-approved therapies for advanced pancreatic cancer. He was one of the leaders involved with getting those drugs approved. His accomplishments include over 800 peer-reviewed publications, leadership as the president of the American Association for Cancer Research, service on the National Cancer Advisory Board, and numerous honors, and achievements, and dedications from patients. And he even has, which I think is amazing, a named lectureship that was established in his honor by the AACR. So definitely well recognized by all his peers. And we can add another important award to his mantle. You know, I've got to know Dan through our shared interest in early detection. Some of my closest oncology colleagues all share the same goal of we got to find it early to give themselves the opportunity for cure. I've worked with him with several consortiums, and I've always found Dan's input invaluable. You have certain people that we all recognize through the years at meetings that when they come up to the microphone, even if you're maybe chatting or distracted, you always stop and listen because they always have that insightful question or observation and thinking out of the box. And Dan's definitely one of the people that I apply that to. You know, so for his visionary leadership, groundbreaking drug development, and lifelong commitment to improving outcomes for pancreatic cancer, please join me in welcoming the recipient of the Ruth Brufsky Award for Pancreatic Cancer Surveillance, Dr. Daniel Van Hoff, who will be giving a talk entitled Giving Pancreas Cancer a Nervous Breakdown. Thanks, Dan.
Well, good morning, everybody, and thank you, Brandon, for a really fantastic introduction, and thank you for this honor. Randy, I'll start with my disclosures. I'll leave it up there a little longer than most people. One of my old buddies, Nick Vogelsang, may he rest in peace, used to say, no conflict, no interest. Well, to pancreas cancer investigators, we often feel like we're trying to push up the stone like Sisyphus did, condemned to hell. But I want to cover some things today that I hope may help us push that rock up the cliff. So in Sudhir's honor, I'm going to talk a little bit about risk first, perhaps help determine who we should evaluate for early detection, and then advanced disease treatment, giving pancreas cancer that nervous breakdown that Randy talked about, and finally prognosis, and perhaps a new stage 5. So we're able to walk into a patient's room and say, well, you have stage 4 pancreas cancer, but you don't have stage 5. So we'll cover that at the end. So let's start with some known risk factors for the disease. I won't go through them, of course, for everybody here, except I thought the most recent one of the number of times that a person consults the internet has become a risk factor for pain. But there are some other risk factors, just 2 that I'll cover briefly here, which we should pay some attention to. And this is the number of cells we have and also their mutational clock rate. So the first lesson, Dr. Brand, I have tremendous respect for you because you always bring it back to the clinic, right? As a young investigator in 1979, we would say, see and take care of your patients yourself. If you do this, many patients and their families will tell you, and they'll teach you deep learning, not artificial intelligence, but I think real intelligence. And keep thinking this is the clinical investigator's laboratory. We often hear from young investigators, I need more protected time. And I will always say, protected from what? From the very patients who are going to be teaching you, to need your special expertise, your caring, and most importantly, your powers of observation. I actually found the best translational investigators are those who try to spend the most time in the clinic. For example, I noticed that most of my patients with pancreas cancer were always taller than I am. Of course, that's kind of easy, I suspect, but Randy and I are in good shape.
I've made the same observation.
There we go, we're in good shape, that's right. Actually, I was fortunate to be born into a great family and a great home. That's my birth date. But I actually used to wish that I had not have been born so short. You can see my loving mother there, and my dad is a bricklayer, taking me, and he also was a Golden Gloves champion. So when I was a little out of line, he used to take me in and show me how fast a boxer he really was. And in that one-room schoolhouse, one of my young classmates at 7 years, almost 8 years old, he developed polio. And we went to visit him. He passed away from polio when he was in iron lung. And although we lined up with really tiny arms and big long needles that were actually autoclaved in between the needles, we all got the Salk vaccine. But as Randy said, now I'm getting older, and I hope that I'm still able to give a talk or 2, but here I am in a nursing home. Hopefully this is my great-great-grandson, and I have no idea where I am, but I'm pretty happy, I think. But my teacher was Mrs. Morgan, Miss Amber Morgan, and she never married. And she said, you know, Dan, you're kind of lucky, but she said some short folks are good for getting under fences. That's the only good thing short people are good for. That didn't do too much for my ego, I guess, but she was right, and I had to live with it. But this thing got worse. You know, short stature. Songs were written about me. Short people have no reason to live. And women like to date men who are tall, dark, and handsome. You know, what about short, pale, and ugly guys? And short men tend to be poorer. I didn't know that before. Less a man's earnings. And my favorite president was Abraham Lincoln. We were both born in a log cabin. I actually was born in a hospital, but that's the log cabin I lived in. My mother said there was snow on the side of my bassinet through the holes in the log cabin, but I was never sick. So my all-time basketball player favorite was David Robinson in San Antonio. So I was looking for something positive in life about being short. And that's when AACR turned me around 50 years ago. There were no height restrictions and appearance restrictions with my bangs. They let me in. And I really felt home. I actually felt taller. And I started reading cancer research. And there it said that taller people have an increase in the incidence of multiple cancers, including pancreas cancer. So that's somewhat, I'm saying, made me happy. But they also taught me there's a very short group of people in Ecuador who never get cancer, almost never get diabetes, and they're, of course, the ones with a mutation in the receptor for human growth hormone, Laron syndrome. There are other medical positives, by the way, before I get off this of being short. You have less heart disease because your atria are smaller, less atrial fibrillation. Shorter individuals are more agile. They don't have accidents as much. They're less likely to divorce. My wife's sitting in the back. Less chance of suffering from heat exhaustion in Arizona, and less chance of DVTs, of all things, because of fewer venous valves and lesser hydrostatic pressure. But more and more interest in human height as a risk factor for cancer, and we go through these, except that taller people, of course, have 1.5 centimeter increase in colon length for every 5 centimeter increase in height. In a recent Korean study just a year ago, 7 to 10% increased risk of pancreas cancer for every 5 centimeters of height. So it appears that the culprit for higher incidence of cancer in tall people is they have a higher number of cells at risk. Then why do large animals like elephants don't get cancer? We call it Peto's paradox, of course. Cancer risk does not correlate at all with the organism's size. Elephants have no cancer. And when I was veterinarian to the Phoenix Zoo, I found out that a colleague, medical oncologist, actually pediatric oncology, showed that the elephant has many more protectors of the genome, TP53, 20 copies or more. And elephants never die of cancer, they die of foot infections. You'd hate to be the person who has to take care of their feet. There are also some new data from these two investigators, which I hope that you've been able to see because it's very, very recent and really controversial, but you'll see that there's a strong correlation between BMI and organ size. And Kristen Tomasetti and Sophie, they've shown that there's an increase in organ volume that actually is due to increased number of cells. So it's not hypertrophy, it's actually hyperplasia. There's 60% of the organ size increase is in number of cells. So double the organ volume, you double the risk of cancer because you have an increased number of cells. Hyperplasia. This was just published about 2 weeks ago in Cancer Research. You can see here easily the size of organs, a difference in BMI, and this is, I think, pretty darn interesting. And if you take a look at the bottom line here, patients with pancreas cancer, their pancreases are 39% larger and a 47% increase in cancer risk. So double the volume, double the number of cells at risk, double the increase in cancer. I think that's a pretty impressive p-value. So a major effect, by the way, is that in patients who have obesity, it is not the increase in just organ size, it's hyperplasia. So obesity is a factor, it can get fat infiltration, but it actually is hyperplasia. More cells at risk. So the other intriguing hypothesis on this risk is there a difference in your baseline mutational rates. So we all have a mutational clock that you're born with or acquire. And you know, you always hear about grandma who went to 103 and smoked 3 or 4 packs a day. How come she didn't get cancer, doctor? Well, probably because she had a very slow mutational clock. And the calculations that if you smoke, it gets 17% faster. I think you're going to hear a lot about this. The question is, how can we measure our mutational clock? Can you do it on white cells? Is it different for each organ? So please take a look at this published last week. I think there'll be a breakthrough here which will help us decide which patients we should really look at very closely for risk. So the bottom line here is stay short and thin with a slow mutational clock, my friends, right? So we have to worry for them, and I hope we have a way to measure that mutational clock. So now into treatment for patients with advanced disease. Now, my first patient as a fellow at the National Cancer Institute, as Randy said, was a 48-year-old Elizabeth Arden cosmetic salesman, nicest man in family. He presented with jaundice. Bilirubin was 42. He was almost green, as many people here would appreciate, and severe back pain, and he had a sister Mary Joseph node, which was easy for even this fellow to biopsy. And it was pancreas cancer, and he died 5 days later. So remember, that's kind of my baseline of pancreas cancer. Again, it's been important to see and take care of patients. I'm going to emphasize throughout this presentation. Spend time with them, and they'll teach you. And this brings me to the first story, is hurry up, doc, I need to get KFC. When I was a young attending physician at the Audie Murphy VA Hospital in San Antonio. And somebody taught me to stop and listen for a second because I was in a hurry. And I said, you got to get your husband to the Kentucky Fried Chicken place? Oh, yes, she said, get to the Kentucky Fried Chicken first because it has the best oil and it tastes the best to him. I looked down, he had a pair of Adidas in those days on, and I said, are you running? Oh, yes, I'm running. And so our San Antonio team was the first to describe a drug just because of that patient eating Kentucky Fried Chicken. When I went to Lilly to try to get this trial funded, I remember the chairman of the board said, young man, are you telling us we want to spend $2 million at that time? That was a lot. On somebody just because one guy ate Kentucky Fried Chicken, and I was so damn scared, I said, yeah, that's about it. And I give them credit because they did fund the study finally. We had an increase in response rate over 0% to 5%, and we did feel that this patient got clinical benefit. They actually had a better performance status, decreased pain, and, to everybody's surprise, an improvement in survival. Not incredible, but an improvement in survival in a randomized trial. There are now 8 FDA-approved NCCN guidelines regimens that improve survival for patients with stage 4 adenocarcinoma of the pancreas. And they're listed here. All these shrink patients' tumors from between 26 and 71% of the time. They all improve survival. We just don't, not enough, but you can see them all outlined here, and you've heard about many this morning. It's not enough. But as you've heard, there was an incredible standing ovation for Ryan Wolpen, and you heard a great presentation of him today when he presented at ASCO the RAS inhibitors. And I think the most remarkable thing about it is the chemistry and obviously the technology of trying to get a molecule that tries to interact with a tennis ball. And we have to remember Kevin Shokot at UCSF and got into the fracas along with Frank McCormick, and it took about 30 years to do this. But they did an impressive job, and this was the first major announcement, as you heard. And just to clarify for those who are not in the area, these are patients who had already progressed on either FOLFIRINOX or nab-paclitaxel, and they were randomized to the RAS inhibitor versus that second-line chemotherapy. It's a 500-patient trial, and it was dramatic results. Overall survival improved, 13 versus 6, and treatment discontinuations were only 1% with the RAS inhibitor, 11% with chemotherapy. But most importantly, what this really did is it reinvigorated the entire field, that something can be done. It's recently published. We don't have time to go through it today, but these are the waterfall plots for second. And in that trial, there were also, not in the randomized one, but just in the phase 2, third line or later, right? And you could actually put a laser pointer between the PFS and survival. Very dramatic, reinvigorates the field. So the next steps, as you've certainly heard, is try to figure out how to take care of the toxicities, which are usually in sun-exposed areas or the back of the throat where the mucositis is or trauma. I'm sure medical oncologists are able to do that as time goes on. And of course, phase 3 randomized trial upfront, nab-pac-gem with or without, and an arm with single agent only. I believe that'll probably take about 1.5 years. But there's a lot published in New England Journal at the same time, degraders of RAS. And there's 29 other RAS inhibitors in development, 29. some specific for the mutation, some not. My only worry here is people will keep looking at various combinations of the RAS inhibitors and we'll take our eye off the ball of getting new targets as time goes on. There are 8 mechanisms of resistance so far. The most frequently is altering RAS with amplification of that target. There's a lot of possibilities for non-genetic, and every combination of the sun is going to be proposed, I'm sure, to take out the resistant clone, and I suspect this tumor will defeat that too in time. Now, I'd like to just give a little credit. Dr. Saluja was nice enough to be here, and he came up with a molecule called Minolide, named after Minnesota, if I say that correctly. And combination, there are many people trying combinations, so we felt we would get in the fracas with that. And the Minolide has single agent activity. But most importantly, it downregulates MYC. And as you saw on that resistance mechanism, upregulation of MYC and MYC coming into the resistance arena is important, and Minolide decreases MYC expression. We just presented this work at AACR, so of course, we're actually going after RAS inhibitor plus Minolide, which, by the way, you might remember comes from the Thunder God vine, natural product. But very recently, one of the presenters this morning mentioned a compound for MTAP, and this is Tango's PRMT5 inhibitor, synthetic lethal with MTAP. And together, these clinically with the RAS inhibitor and the MTAP inhibitor, 92% response rate. I never thought I'd see it cross over 50. And also in non-small cell lung cancer, 3 out of 3, this is in the phase 1 trial. And there's no dose-limiting toxicity. This is kind of mild stuff. Some people say it's almost like giving water together. Now, we also should not forget FDA approval this year and EMEA approval for what you have outside this door, the electrical tumor treating fields. This, of course, was pretty dramatic when it was utilized in patients with GBM. It improved survival, 2-year survivorship up to 30%, then mesothelioma, then non-small cell lung cancer, and if you really think of it, non-small lung cancer brain metastases also. So they want to be doing good science, and they conducted this trial with 571 patients, chemotherapy with tumor treating fields for locally advanced patients versus chemotherapy. There was an improvement in survival, not super dramatic, but definitely a big study and consistent. And this was published very recently. Very impressive to me was the improvement in pain-free survival from 9 to 15 months. Who wouldn't go for that? The science is better now, I think. But one thing we always say, you got to be alive to get the next breakthrough. Any little advance helps. Besides mutated RAS, what are some of the other toxicities? And this kind of comes to the beginning, the title of my talk. Pancreas cancer cells are under stress. Our hypothesis is if you increase the stress, maybe we can get them to apoptose, leaves falling off a tree, and this is where I think activating death receptor 5 is. And then a second vulnerability, we'll call them senescent cells. I like to call them zombie cells. They hang around. This is our tiny group. Some people show big groups. I think it's easier to work with a tiny group. TGen and City of Hope. This also includes our admin group, which we're always glad it also is tiny. In our search for these contexts of vulnerabilities, we actually have found stress. These tumors, no matter what you throw at them, just think about it, they survive. It's a bag of enzymes, lots of mutations, lots of scars, poor blood supply. They have a syrup-like environment that they live in, very low glucose proteins, and high vascular endothelial growth factor. It's very inflammatory. I never thought about it much, but with all the psychological stress, you have high catecholamines that have been shown to drive tumors. And under that stress of chemotherapy, no matter what we do, they survive. There's persisters, right? The amazing thing is they still have to make DNA, RNA, proteins, and metabolize. How in the world did they do that? Look at the number of chromosomes. That's always amazing to me. How can the cells even divide? They're clever. So our working hypothesis is that these cancer cells are under considerable stress, particularly proteotoxic stress, right? Just like the acinar cells. They got to make a lot of proteins. And we can increase that stress. Could we do that and actually trigger the cells like leaves on a tree. Now, we know leaves on a tree require for them to fall off. You'd think, okay, it's getting colder, especially in Minnesota, or it's light, right? It has to be dark. But it also turns out to be moisture, so there's three things that you really have to get cells. So we're trying to push them off a cliff and selectively trigger that. So our clinical trial methods to try to increase this stress on tumor cells, in other words, activate that death cascade, have been three. First of all, we said, how about oxidative stress? So we'll try the high-dose ascorbate plus gem, platinum, and nab-paclitaxel. Then we went to cytotoxic stress, which I won't cover because I'm ashamed that we put together 7 drugs, and you might imagine it was too toxic. The third, caloric stress, you'll see here in a minute. So oxidative and caloric. So oxidative, we did a phase 1b/2 of high-dose ascorbic acid. We call it the Tejan triple plus, and these are all patients with stage 4 and couldn't have G6PD deficiency, of course. And we had 25, 32, and 56 grams per meter square twice a week. Target plasma level outlined there. These patients, when they got that high dose, were hungry, so hungry they would eat the chair, thirsty because tremendous osmolality and some other toxicities. And this was actually funded by Destroy Pancreas Cancer Group out of Atlanta. Our clinical observations is a very active regimen, but we didn't think it was any better than the already guidelines. Tejan triple plus high dose was probably not better. We had a 60% response rate. Our conclusion was it didn't add much, but there was another interesting finding, and I put in here for the GI doctors. 4 out of the 4 patients that had fatty liver, if you let me use that term here, they actually cleared their fatty liver. And they cleared it really rapidly. And we wondered, did that really help patients? Well, 3 of the 4 of those patients had fairly dramatic responses, but I just put it into your thinking that high-dose ascorbate definitely clears fatty liver. The next finding in the lab from Josh Rabinowitz, who's at Princeton, was that a ketogenic diet or caloric stress puts them under further stress. Now, the ketogenic diet by itself, as you can see in these pretty carefully done experiments and published in good places, did not do anything to tumor growth. But we gave it put together with chemotherapy with that caloric restriction is pretty dramatic. So we did a randomized trial, didn't have a lot of dollars, so it's small, but it was just published in Cancer this month. Was the progression-free survival there, as you could see, was prolonged. These are only 16 people per arm. It was sponsored by Purple Pansies. And the Youngs, and the overall survival also was increased, even in a small subset of studies. This was very professionally done, tough group, monitoring the patients every day for the ketosis and remote monitoring. We're just wondering now, what else should we add here? Should the RAS inhibitor be put together with this? It can be done. Finally, to try to go along our hypothesis, is there any other way to activate this apoptosis? So we had done some work a couple years ago, 4 now, with Fred Hutchinson group, and knocked out every gene we could with RNAi. And no matter what we did, it didn't help unless you triggered the death receptor to cause activosis. And people have tried for years to do this. Death receptor 5 is a surface protein. Good start. Density is higher in tumor cells than normal cells. It usually binds TRAIL, the TNF-related apoptosis-inducing ligand, to trigger apoptosis. In the early days, maybe Dr. Brand remembers this, we tried in San Antonio to give tumor necrosis factor to activate it. And the first patient that I personally treated, I turned around and I heard this thud, and he had fallen off his gurney. The chills were so severe. So no go for tumor necrosis factor. There have been other ones. I'll just go to Inhibrx down there that DR5 agonist had responses in chondrosarcoma patients. And the nice thing is you can actually measure DR5 in patients with PET scan. So the key here is to try to bind this DR5 receptor to induce. You have to actually have a consolidation of those receptors. So increase stress, get some ligand to bind it, go the cascade of proteases, apoptosis. This is extrinsic way of trying to activate apoptosis. A recent call, and he had just published a publication, we came from a fellow here that developed 3 breakthrough drugs for the FDA, all antibody drug conjugates. Victor Goldmacher. I call him Batman because he described bispecific apoptosis triggering, just what we needed, right? His new approach is called that, and he went after MUC16. Now, we would know that as CA125, and when we get in trouble for looking for CA19-9, we look for CA125, and it's there. So he developed this antibody, this bispecific, doesn't have any kind of warhead on it at all. What it does is it binds CA125, and at the same, which is a very large protein on the cell surface, and then at the same time coalesces DR5. MUC16 is interesting. I just said a word about it, but it's certainly included on the basal squamous, Joe, which you asked that question. And it promotes tumor progression. I didn't know that, and it activates pathways, and it also causes a higher mutational burden, which I also did not know. But interesting target. It's a big protein, right? So the general idea here is you can see this antibody, a bispecific called IMVM, binds MUC16 and at the same time coalesces and causes this triggering of apoptosis by getting DR5 receptors together, estimated about 4 to 5. MUC16 is clinically validated. You can see the variety of tumors. It's lung and breast, and of course ovarian cancer in the first pink bar there, of course. So it's got a lot of applications. And DR5 is positive like crazy in pancreatic cancer. And so they produced some data that showed that no matter what the dose of it was, pretty much this just buried tumors. And then we took it into our laboratory. And this is one of the most, in fact, it is the most active thing we have ever seen in these in vivo models. It just buries this tumor. And I want to say somebody called me a few months ago and said, what do you want to do, Dan? I have an extra $1 million, right? You don't get that call every day. And we said, we want to test this thing. And just to show you, because nobody ever shows you the individual tumors in the mice, they're all buried. And this is actually more active than the RAS inhibitors. Doesn't have any side effects. It's already been in animals, have been in primates. So we want to get this into patients as soon as possible. The second context of vulnerability are the zombie cells, because no matter what, all of us in this room know that some of these cells will survive. They're persisters, right? So we have a new target there called advanced glycation endpoint, which is actually in senescent cells. So if we have damaged cells from whatever treatment they've had, they can undergo programmed cell death. Maybe our IMVM will do that. But there will be some to revert, to continue to proliferate. We can knock those off. But the ones that become senescents are a real problem because they're growth arrested, they're non-dividing, and they actually, believe it or not, act of a way to kind of feed and promote the tumor growth. Some say it's pro-inflammatory. They actually make secreted proteins, and they remodel the whole microenvironment that we heard about this morning from Dr. Zen. So what can we use? They call them senolytics now to selectively kill these zombie cells. Well, here's the marker that all the cells have. There's an antibody now that actually hits these and is going to be a great tool for hitting cellular senescence, to get these outliers, to get these senescent cells, I'll say it that way. But persisters is the word I was looking for. And we've tested this in vitro and in vivo, and again, very impressive improvements in survival. But most important is point number 2. Remember I said KRAS amplified was the way, the most, 80% of the resistance to the RAS inhibitors, amplification. This actually takes out amplified RAS cells. Some more information there. So finally, I'd like to discuss prognosis. Can patients tolerate being on a clinical trial? Second of all is, can we predict when they will die? And why do patients die anyway from cancer? Anybody who's worked in hospice knows sometimes people can have tumor all over the place, and they didn't die. I'll go back, Randy, to my great time at PNS. where I was on GI rotation, and all we had in those days to do peptic ulcer size between barium, they made us look at the number of furrows in a person's forehead, right? And if they did have 3 furrows, then they had peptic ulcer disease. And like Shakespeare knew that already. I have pain upon my forehead here. So there was a great trial at Walter Reed, which actually showed that this was pretty good, right? But some great investigators up at Dana-Farber and MIT who said, how about we take pictures, right, and do serial pictures? And they started a company called FaceAge. FaceAge model is amazing, trained on some 60,000 people from the internet you can get, and there were 6,000 people with a cancer diagnosis. And I will tell you, this is fairly impressive. Please take a look at this article, that patients with cancer looked older by 5 years than their chronologic age, and it improved physician survival prediction, rather dramatic. And in lung cancer, it was the best of all. Maybe it was because of prior smoking, who knows? But you know, there's millions of pieces of information as you go through the airport they collect every minute. I think insurers would like to have this in their hands. But it was remarkable. For patients with breast cancer, it was a better predictor, and GI cancer, and GU cancer, and lung cancer, just with a selfie. Now the question is, what can we do? Now, I would just say somebody like Dr. Mandir is the kind of medical oncology fellow or medical oncology young faculty member coming now. He's got an engineering degree, machine engineering, AI science, learning, Stanford, spent 7 or 8 years at BlackRock, okay, deciding whether or not something was going to be worth investing in. Then goes back, gets a medical degree, MD at UCSF, and his area is translational AI. So the idea here is take patients, people, just say people, totally staged patients with resectable or borderline resectable, and ask ourselves, we'll take a picture every week, and then do our baseline and begin the neoadjuvant therapy, 3 to 4 cycles, see if they're hospitalized, see what trouble they have, and then when appropriate, take to surgery, go through surgery, and take a picture for the next 12 weeks. Because you and I all know that sometimes there's a person who walks through the door who said, she's a good 80, right? How do we really, it's clinical judgment. We need all the help we can get. And this trial is going to see whether we can see those people who are going to have terrible grade 4 or 5 toxicities, more than 14 days in the hospital and survival. Very anxious to get this information. If everybody wants to participate, love to have you. And finally, we have to ask ourselves one other important question. Some of the smartest people I've interacted with have said, Dan, why do people die from cancer? Oh, that's easy. You know, we said tumor, it's all over the place. Death certificate says cancer, must be true. Metastatic cancer leads to a lot of things, as everybody here, your liver failure, sepsis. But this is to introduce you to stage 5, and please take a look at this great paper in Nature Reviews Cancer. So this brings us to what is stage 5 cancer. Will it tell us how long a patient has to live? And this is Matteo Longorio. He's at UT Southwestern now. He says, he ran up to me, he said, ran up and said, I know why patients die from cancer. Would you stop and help and find a way to reverse this stage 5 disease? So a lot's been written about patients dying from cancer. You know, they've been feeling sick all the time. They're just ready to go, blood clots and other factors. But the new hypothesis right now is death ultimately is caused by colonization of cancer cells within the wall and lumen of huge, large vessels, which leads to clusters in that area. We're going to call it macrovascular invasion. And what can we do to stop it? Now, in my time in covering hospice, we made many, many calls, and there are lots of interesting observations, but he took it to another level and started measuring blood, taking blood from patients in hospice, and then when they passed away, he actually did warm autopsies, which we had done with the Hopkins team many years before. And he took them in the middle of the night, et cetera, and then went back and looked at all their x-rays and said, 21 hospice patients, 10 with cancer, 10 without, 21 with cancer, 10 without cancer. And in cancer patients, he noticed that in those last 21 days of life, they all of a sudden had clumps of tumor cells, clumps. Right? If you took a look at it, you can see here the last 21 days of life. If you have clumps, no one survives that. And you don't see these clumps before those 21 days. If you go back and look at these patients' x-rays, you can actually see their macrovascular invasion. And that's the thing today, as you go back to your practices, you can see it on CT scans. You can certainly say, well, okay, the aorta seems as pushing on it, right? Or you've got the portal vein, of course. We're not going to operate on that patient, or I can, or whatever. But this is really colonization, probably, of the vascular system. This is super important. If you knew 21 days before a person was dying, what guys say, would you offer a clinical trial? We certainly would like to tell them so they can make these decisions, because if you go into a phase 1 trial, we know it takes about 25% of your time. And you know there's this rapid people dying on all pancreas cancer trials. There's always that rapid dying in the 6 weeks. Please go back home and take a look at this. Should we stratify for clinical trials? This is stage 5 cancer. So the implication is as I said, take a look, and can we detect this imminent mortality? And this could be a window for molecular mechanisms, and there's a great editorial by Dr. Matra et al. That accompanies this paper that says, you know, is this activating the cardiovascular system for arrhythmias? What exactly is going on in this stage 5 disease? So we could do a trial, right? Matteo's a surgeon, he would like to cut it out, right? But that's probably not going to happen. So here's one trial, patients with pancreas cancer with macrovascular invasion, best supportive care plus radiation, or focused ultrasound, or float a catheter up there, versus best supportive care. And same thing is true here. We might use tumor treating fields. Certainly you can cover the portal system versus best supportive care. And the endpoint is not a tough one. It's just a number of CTCs and a number of clusters of tumor cells. And of course, if you were an optimist, you'd say survival. I think things are improving in biotech right now. We're starting to hear again about 2 new agents a week. One of them actually is elephant P53. And you can see the list here is rather large. And the RAS has just reinvigorated the field of people wanting to take a swing at this. I want to end this by saying thank you to my clinical trial colleagues at Honor Health and also now at City of Hope. I couldn't report any of this without my colleagues. This is our pancreas TGen at Translational Genomics Research Institute. This is my national advisory board, and you can see we have people from the Boston Red Sox and the New York Yankees, and they actually are on the phone and in the room occasionally together. And a lot of great people devoting time to help us raise the funds to do it. These are some of the folks who put the support together for those $1 million to try these new things. And you can see, I just want to give credit to the Navy SEAL down there who was the fellow that went out to try to get, his name is Hatch, Bo Bergdahl. When the Taliban had him and he got shot in the femur and took years to rehabilitate. For one of our fundraisers, he gave the following. I don't know who would bid on it here, but he would take you up to 24,000 feet, jump you out of an airplane. This is for 3, take your buddies, and then stay in the Atlanta area wilderness. Actually, it was outside in Georgia for 3 days, see if you could survive. I was very surprised. People bid on it. It went for $120,000. They videotaped it, and guess what? The next year, they bid on it again. So this is a great fundraiser, and we appreciate that very much. And you can see we have Superman and Superwoman down there. I'm sorry, it went the wrong way. And I want to thank you for the honor, Randy, of giving this lecture, and so many more people and wonderful people, all of whom we're pictured here. We lost many who participated in these clinical trials. And, by the way, there are things worse than being born short. I did find a lady, she's sitting in the back there, Ann Shields-Layton, who would marry me. There we are, nice and thin, walking down the aisle. We had 3 children, Paul, Jane, and Carol. I'm glad I can remember their names. And then we had 9 grandchildren, which Ann names the Divine 9. And who knows, what awaits us in the future here in the ocean of life. 53 plus years of married bliss, I think. And except for a sure thing that we as elders are definitely going to continue to get shorter. Thank you.
It was a fantastic talk. I just wanted to give Dan the plaque, recognizing this
you.
Thank you.
Andy, thank you so much.
Thank you. And I don't know, did we want to just have people come? I guess we have time for, people can come find Dr. Von Hoff because we reached the noon hour. We have 1 hour for lunch. Please visit the exhibitors, and then we will have our next session start up at 1 p.m. But thank you.